don't think Gordon needs any introduction. Let's move on.
Janice Bates was meant to be talking today, I think, about infection control and such like, and diseases and bugs, and she's not going to be able to be here. And I've wanted to talk about ward rounds for some time, and so I'm prepared to talk. Hopefully it won't go along the whole way through the 45 minutes, just about my interest in ward rounds. This picture I'm showing you is around the topic that Richard was alluding to there, about innovations that can make a big difference to the way we work on a daily basis, yet don't seem to get taken up and rolled out. This is a trolley which actually I had the manufacturer make after we'd trialled a trolley on our ward rounds for about 6 or 9 months, and we think it transforms our work, to the extent that when I move off Ditchling and go to Coombs, I immediately start to get grumpy because there's nowhere for the juniors to hold the notes, nowhere for them to put the notes, nowhere for them to write the notes legibly, and you have a scrum with everybody trying to get the notes. So we have a trolley like this on Ditchling with 8 drawers on it, 1 for each bay, the patient's notes go into 6 of the drawers with the nursing notes. We've got fold-out tables on either side. So when we go on the ward round, you've got somewhere to put the notes, and when the physio comes in and says, can I have the patient's notes from bed 3, to look at them, you just pull it out and take the notes out. Saves so much time, gives you so much surface to write on, makes the notes legible, very productive. They cost £600 each. I reckon they pay for themselves in a week. But you can't drive that sort of thing through our trust for some reason. And the return, if every ward had this, within a week, everybody would feel that working was much easier. So that was sort of starting with a moan, I suppose. So I'm going to talk about ward rounds, and just when I was preparing this yesterday, I just thought I'd go into the story behind it. Around about 2004, this is a gentleman under my care. That horrible thing on his arm is a cannula site infection. It had MRSA in it. So he stayed in hospital for 4 extra weeks at that time, having intravenous antibiotics for an MRSA infection, because we hadn't taken the cannula out of his arm that he didn't need in the first place. And that made me wonder, how is it that we can end up harming our patients so readily in hospital? What are we doing that means that we result in harm like that? I did some work with the chief executive at that stage on how we could try and get junior doctors to review the cannula on every ward round, take it out when it was necessary. And I remember talking to the registrar and saying, couldn't you build it into a sort of daily review schedule, maybe carry it around on something the size of a postcard, this is what you're going to do for every patient, and you put a cannula site check in. But nobody took it up. Actually, before that, thinking about it, because it was a different chief executive, I did an audit on post-take ward rounds. This is King's College Hospital where I trained, and a nice quiet ward, Nightingale ward. You can see all the patients, there's plenty of nurses there, there's no panic, it's all calm and everything's happening nicely, which did not match with what was happening on the post-take ward rounds in the acute medical unit, where we didn't have nurses. The phone was ringing constantly, the floor was being cleaned, the televisions were on, somebody was bringing the drinks round for the patients. We were trying to be detectives and sort out what on earth was going on with the patient so we could solve the crime that had happened to the patient's health, and the bleeps were just going and going and going. I can clearly remember a ward round where I was trying to auscultate a patient's heart. I'd had to put my head round the television set that was hanging down from the ceiling, whilst the patient was on the mobile phone trying to talk to their relative, and the cleaner was buffing my shoes with the cleaning device. That's what led to this audit, which we presented to Roger Green, who was chief executive at that time, and had a really surprising outcome from that audit, because Roger Green saw to it that the cleaning schedule was moved to the afternoon, he had the televisions removed from the acute medical unit, and he had the phones removed from the acute medical unit. He dealt with all of those problems and immediately made the place more conducive to work. What his comment was, and he was sitting where Richard is now, once we'd done the presentation, he said, you doctors don't have any process for your ward rounds, do you? And I didn't know what he was talking about, because I didn't know about process and business and organisation in those days. My interest continued from there when 2006, and all you poor junior doctors were exposed to modernising medical careers and workplace-based assessments. And they seemed to want to train you to do all sorts of extraordinary things, like examine somebody's chest without any idea of the history or the background and why you might want to examine the chest, or take you away and do Breaking Bad news to somebody who was an actor or something. And I wasn't interested in all that. I wanted to see whether I could make you do your work better. Could you do the clinical work better? How could I provide assessment and training and formative assessment and development actually on ward rounds? And particularly one of the big things in modernising medical careers they didn't talk about at all for registrars, how do you train a registrar to do a ward round? So when he's a consultant, he does a good ward round. So I was much more interested in this idea of assessment, interested in development of junior doctors, feedback and training, but they seem to be missing the point. So I was interested, could I train SPR to lead a ward round? How can I help the juniors to develop whilst we're doing a ward round? So that's where my interest in ward rounds, I think, came from. The other point which I often say to the juniors, if you want to do an audit or you want to do a study on something, do something that's so common you don't need to spend hours finding it. And ward rounds are really, really common. If you want to do oxygen prescribing audits, drug chart audits, anything that happens all the time, you don't have to wait 6 years to accumulate the data. So this talk about ward rounds, I think it's a good idea to set this in the context of what I think the job of acute hospital services is. And I think our work is to take a cohort of patients with acute major clinical conditions, swiftly improve their health so they can safely resume living outside hospital. And I use the word cohort a lot more now. I used to think I looked after individual patients, but if you think that you've got a cohort of patients, like I had 19 to see on the ward round this morning, it's important that I see all 19 and deal with all 19 problems, and don't allow one person to subsume all the effort. So we need to work so that we can look after the whole cohort of patients. Small proportion of our cohort, our work is to anticipate end of life and provide for a calm death. And I think also our work is constantly be training ourselves, bettering ourselves, and training and improving the next generation of healthcare professionals to deliver ever higher quality clinical care. Andy was talking about the NHS reforms and the changes that are going through. One of our big worries with the NHS reforms is that there won't be an emphasis on training, and it will just be a service provider who does lots of endoscopies and never trains anybody to do an endoscopy. And I think the practice of medicine is like the flow of blood. It's red cells and it's plasma, and the two need to be together, and if you try and split them off, it's not much use in the circulation. So we must always be emphasising training, because our work is practice, not just knowledge, it's practice. What that comes down to for us as doctors is that we've got to make the right diagnoses in the right overall context with the comorbidities of the patient, provide the right treatments, the right time, right place, really important. I've got a man on Ditchling ward this morning in hepatic encephalopathy with alcoholic liver disease who should be being looked after on Darrington ward, where you've got the experts to look after him. He won't do as well on Ditchling as he would do on Darrington. Right to no avoidable harm. Are we actively harming patients? Better next time the training. And it's the whole cohort. If you read about the Department of Health and you look in your clerking proformas, they want you to sort out community-acquired pneumonia, COPD, acute myocardial infarction, stroke. What else they want us to do, Prashant? I can't remember. There's 3 or 4 conditions they really concentrate on. And the danger then is, if you've got somebody coming in, you think they've got community-acquired pneumonia, you get on and crack on and manage them, whereas the person who's really ill hasn't got a clear diagnosis, you think that's all right because they're not a quick target. So it has to be the whole cohort of patients we look after. And the pace of our work is really important, and something, as far as I can see, is completely ignored in terms of inpatient care. Our work must easily outpace the progress of the diseases in our cohort of patients. If we're constantly held up and slow, then patients' conditions advance and deteriorate because we're doing our work slowly. For example, I was told a couple of weeks ago that there's a new falls assessment form being put into A&E, and we know about that? So it's another piece of paper stuck on front of the notes that everybody's got to fill in. Now, nobody has thought, well, let's measure the pace of work before we put that in, then put it in and see what it does to the pace of the work. And we all know what it will do. It will slow the pace of work. People won't fill the form in, so we're slower, and we've demonstrated we're not doing the work well, so we're open to criticism. So thinking about the pace of work is really important. Do our innovations speed or slow our work? And a lot of innovations cause a temporary slowing, but then must speed things up. So Richard will have seen this with the introduction of Patient Track. Maybe initially the nurses work a little bit slower for 2 or 3 days, then everything's much quicker. So there may be a little bit of slowing early on. When thinking about ward rounds, if you go to literature and try and research what a ward round is, there seems very little definition of what a ward round is, which makes it difficult to discuss, difficult to study. I think it's a bit like a pit stop for a Formula One car. It's a day, it's a service, it's an episode of service, of patient care, of assessment of what's wrong, progress of the patient. If you think of a Formula One pit stop, you can see it there. Everybody's highly trained, everybody knows what their job is, and every single person there is active. And if you're a consultant, next time you're on a ward round, if you're lucky and you've got 3 or 4 people with you on the ward round, look around and see how many people are like that on the ward round. And I change roles around in my ward round, and I stand sometimes and write the notes or look at the drug charts, and I get bored really quickly because I've done my bit. And maybe we can be much more active, maybe we can work together. So I think a ward round is a series of structured clinical reviews for the cohort of patients in the team's care. I'm trying a bit to get away from the word ward round because it implies a particular solution. So for example, in Sweden, I'm in touch with people where they've built a room which they take the patients to. So that's obviously better for confidentiality, better use of IT resources. You don't need a computer at every bedside if you're taking the patients to the room. Obviously there's limitations that some patients won't be able to go to the room, but different way of thinking. A lot of acute medical units may not do a formal ward round, but they do a series of senior clinical reviews. I think you can define an acutely ill patient as somebody who needs a structured clinical review every day. Richard, in the ITU, you do clinical reviews 3 times a day, probably, structured reviews?
Twice a day.
Or twice a day, ITU. I think on SQ they were aiming for 3 times a day. Your haematology patients may well need 2. So the more sick you are, the more frequent you need it. But I don't think, if you're in hospital, you need it every day. And you know that makes sense because when you work at weekends, you see people really deteriorating, really getting sick and dying because they're not getting a planned, anticipated, structured review. They only get seen once something bad's gone wrong. So when daily errors, clinical reviews are not happening, errors, morbidity, mortality increase. The medical director and the chief executive know that as well. Their complaints and incidents and serious untoward events happen when the daily clinical reviews aren't taking place. We do ward rounds every day. Sidney Dekker, in one of the books at the back there, he talks about the biggest threat to a modern organisation is what people accept as ordinary. So you don't think about ward rounds because they're so ordinary. And if the ordinary thing on a ward round is it's not very good, you accept that not very good is ordinary, and you don't think about it and things go wrong. I think ward rounds, now that I've reflected about them, are possibly the most complex human activity that there is. I think it's probably more difficult to run a good ward round than to put a man on the moon. Because you've got this complex interaction of clinical events, the emotional, psychological reactions of the patients, ethical issues, legal issues, family issues, work, financial issues, cost, external regulation, internal regulation, dealing with spoken and written word, the misunderstandings that arise from that, the use of IT, does the IT really support the ward round, all the team factors, the personality factors that are happening in a ward round make it really complex. I was thinking when I walked to work this morning, that's why there's so much on the television. There's so many programmed dramas that are medicine, there are so many documentaries that are medicine, because it's fascinating, because it's all about life and death, very complex what's going on, yet you don't realise it. One a medical student who'd done some work with me studying ward rounds said, now that I've worked with you, looked at a ward round, I realise it's no longer a social parade round the wards of just being nice to people. And that's really what he thought a ward round was at that stage. And they're very time limited. Again, coming back to this pace of work, something that we and our managers don't seem to understand is it's time limited. On an aeroplane, they have very complex processes and procedures to go through, a lot of organisation, but you know that you're going to take off from London and 7 hours later you're going to land at New York, and you can't make it 14 hours because the plane will fall out of the sky. And people tend to put more and more stuff onto us all the time, saying you've got to do this, you've got to do this. All the time we've got to be outpacing the work of the illnesses in our cohort of patients. So everything we design for the ward round should be to optimise it, make it smoother, make it quicker, but safer as well. Particularly this sort of time of year, we're under so much pressure. Get the patient out that you think the answer is to hurry the ward round. If we hurry the ward round and we're not safe, things will go badly wrong. So it's a very complex activity. And I've put erring rather than errors. Errors in our society, in our culture, imply blame. Again, Sidney Dekker's book on that is brilliant, about the effect of a Western way of thinking that something's gone wrong, somebody's to blame. Whereas I much prefer to think of things of us erring. So if you err in diagnosis, you can imagine a little track in the foggy weather, and you're sort of wandering around the track, and where do you go, and do you err and fall off the edge? And that a lot of what happens to us is not deliberate error, not deliberate actions, but erring and things that make us err more. And any error can have a huge impact on a patient. So that first patient I showed you stayed in hospital 4 weeks extra with an MRSA septicemia because we didn't, well, first thing we put a cannula in we didn't need, then we didn't take it out, then he stayed in hospital for 4 weeks. And a lot of our errors have even more potential than that. And error is common in complex processes. So what happens when a complex process fails? And I know in this trust everybody was delighted when Toyota ran into trouble a couple of years ago, because I've been talking so much about Toyota systems and how good they were and how they optimized systems and really drove things forward and went for excellence. So they're all delighted when people were ending up in the ditch because of some problem with their brake systems. So when complex processes fail, there are big problems come through, and there are big errors, major outcomes. So I've said that a ward round, I think, is a very complex process. So what happens when complex processes fail? What happens when you've bought your Toyota car and you end up in the ditch? You are suddenly very interested in what was the process of manufacture of a car in Toyota. What was the process? Was it standardized? Was it well designed? Were the materials bought to standard? This morning, again, walking to hospital, I asked why they dug up outside the new outpatient block. They put in a low voltage cable instead of a high voltage cable. Then they bent the high voltage cable, and they're now on their third cable. So the materials weren't to standard in the first place. Were the staff well trained? Was the process easy to get right? And apparently if you go to a Toyota factory or BMW factory in Chichester, you look at the shop floor, everything's laid out, it's easy to get it right. There's a sense of calm, organisation and flow, which is not what I feel when I go onto the wards. And what was the quality control? Was everybody checking to make sure the thing went right? I think, Andy's now on his iPhone, I think they expect to get something like 99.99 perfect products off an iPod line, production line, don't they? 99.99, absolutely perfect. And they know they're in trouble if they get a few duff ones coming through and then mass publicity and the sales plummet. So what was the quality control? So if you think about ward rounds as a highly complex process, when I started to think about this, and Roger Green had said to me, none of you doctors have a process, well, what was the process? I had never described the process. My juniors just have to know that I turn up at a certain time and get on with the ward round, and after a couple of weeks they've got an idea how I did it. So I'd never described the process. Was it standardised? No, I could vary from day to day. One day I might do it one day I might do it another. Was it well designed? Well, my ward rounds had never been designed. Were the materials to standard? Well, our materials aren't to standard. We don't know what the specifications are. I don't think anybody would ever sat down and said, let's specify a system where you have to enter the hospital number into the blood test results, the microbiology results, the x-ray results, after 3 or 4 logons, just so you can see the basic clinical care of the patient. That's not to specification. It doesn't fit the pace of work, but nobody had set the specifications. Are staff well trained in ward rounds? No, you're never trained in how to do a ward round. I was never trained in how to do a ward round. It was all this learned by osmosis. And are the processes easy to get right? No. Any of you on this weekend? You're lucky. No, chin is, you know when you get to the review a patient, somebody's done a ward round, but you don't know what was wrong with the patient. The processes aren't set up. It's not easy to get right. Document what's wrong with the patient. Document what the anticipated trajectory is and know what's going on with the patient. What's the quality control on your ward rounds? There are a few consultants here. What's the quality control on your ward round?
Mine's the pharmacist, the senior nurse,
So,
and all of you.
they're just there, aren't they? But if you went to a motorway service station, what's the quality control on cleaning of the toilets? It's there on the wall. You can see the list. You know when it was last cleaned. And if there's a really messy toilet, then they can find out who was responsible and what was going on. I would argue there has been no quality control in ward rounds and no demonstrable quality control that you've actually done the thing. So do ward rounds result in erring and harm? Yes. Some of you may have read my paper, short paper in the BMJ last year on misdiagnosis. Misdiagnosis is probably the major cause of harm to patients. And I can think of a patient 2 years ago, almost to the day now, who died of a pulmonary embolism when I and a consultant in respiratory medicine had been treating the patient for pneumonia. When you went back through the notes, you could not understand why we'd hadn't treated him for pulmonary embolism. And a whole lot of that is to do with erring, really busy times, difficult to see x-rays. How did the juniors present the case? Did we look at all the results? Did we have time to look at all the results? No, we ended up with the wrong diagnosis and the patient was dead. Misdiagnosis, very easy. And missed diagnoses. We had a very difficult case last year where a patient had been on coronary care, and through the admission, none of us had looked at the x-ray. Came back 4 months later, 5 months later, with advanced lung cancer, and he had a tiny shadow on his original x-ray, just because we didn't look at the x-ray. We didn't have a process, didn't have quality control. So misdiagnosis is probably the leading cause of harm to patients, and actually very difficult to identify because we don't even agree on the words to use for the diagnosis. And it's very easy to, we're all convinced we got the diagnosis right, which doesn't open you up to the fact it might have been wrong. Then the ones that are easy to measure, drug errors, deaths, serious harm to patients, serious harm to staff, serious harm to the organisation. So it's no secret that a patient died at Chichester, 18 months ago now, Richard, I think, something like that, with an error to do with digoxin. So the patient was dead, families devastated, 3 professional members of staff, their careers in ruins because of a drug error. And drug errors are really dangerous, really important, and the effect, I think the effect on staff and the organisation isn't emphasised. It's at least as much as the effect on the patients. Morbidity, on ward rounds, if we may fail to pick up on things that result in pulmonary embolism, pressure area damage. I saw a woman this morning on the ward round who's got the grade 2 pressure sore on her buttocks that the nurses seem not to have identified and not be treating, and she's been in hospital for 2 weeks. Cannula site infections, immobility. Immobility, huge cause of morbidity to patients. Another lady on my ward round this morning should never have come into hospital. When she came into hospital, she fell over. She's now been in hospital 5 days. Is she going to get pneumonia before she gets out of hospital? So she shouldn't have come in. We've made her immobile. She fell over, delayed discharge. And miscommunication, complaints, litigation. If you work as medical director or chief executive, you know all these things happen commonly. So yes, ward rounds do result in erring and harm. So now what is my process? The process for the ward round today, thorough notes and results review before going to the bedside. That's difficult. We've got a little area in Ditchling where we can do that. We take the phone off the hook and we get complaints from administration. We shouldn't have done that, so we get some peace and quiet. Endless people coming in to interrupt us. I put a problems list onto my laptop now on Sema Helix, so that when I get to the bedside, I can rehearse the problem list back to the patient and say, you are in hospital because you've got bronchopneumonia on top of COPD, on top of type 2 diabetes, chronic kidney disease, ischemic heart disease, and pressure ulcer. So they know that we know what we're dealing with. I've shown you the trolley that we use. We take that round with us and fold out the writing surfaces, and that gives us a sort of mobile office at the bedside. At the bedside, you have social introductions and then a professional introduction. You're in hospital because Dr. Eggleston has made a diagnosis of left lower lobe pneumonia in the context of asthma. You're also an ex-IV drug abuser. You drink alcohol to excess, and we've got unexplained confusion in your case today.
Patient. Was that introducing the staff members with you?
Yes. Yeah.
Sorry, that's a shame.
That's right. I see what you mean, Nick. Yes, I'm with you. Wasn't quick enough on that. Yep. So that's just the staff, and then you get on to the patient. Yeah. Then we're looking for a report on the patient's own report on their progress, ideally a nurse's report on the progress, review the vital signs, examine the patient if necessary, look at the drug chart, bedside chart review, and active safety checking, plan the tests, anticipate progress, estimate the discharge, senior of care, sum up, sign off the notes, and quality control. 7-point... Sorry? Coming to that. 7-point active safety check. We ask this on every patient. If we had a nurse with us at the bedside, I could expect the nurse to give a report on these issues. Or a patient themselves should be able to give some input. Pain or discomfort, we found we weren't dealing with pain and discomfort very well. Eating and drinking, I found out that I had very little interest in eating and drinking. Since we've been interested in eating and drinking, patients' nutrition much better. Hardly have people on drips at all, whereas they used to be on drips, because now you find they're not drinking. You say to the nurses, get this person drinking, you don't need a drip. Diarrhea is obviously to do with C. diff. Number of patients who are constipated that need dealing with, that's significant. Problems with bladder control or catheterisation. Any issues with pressure area care, like we picked up one lady this morning with pressure area care. The nurses hadn't picked up the problem. Additional difficulty there. No nurse with us on the ward round, so as far as I know, no nurse yet knows about that pressure area problem, because we haven't found a nurse to talk to. Any IV cannula or lines, and amazing where people hide their cannulas and you think they haven't got them. I can remember a person who's completely fit and well. We said you can go home, and he then pulled his sleeves up and he had a cannula in both elbows. Why? I don't know, but they were there. And then do you need to change the VTE thromboprophylaxis? So 7-point active safety check. The quality control, I haven't shown you the detail of my checklist because I don't think the detail is important. The principle is important. This is a highly complex activity, time-limited pressure, lots of errors potential. There should be some system to check that you've done everything. And by introducing our system of this considerative checklist, it's actually enforced a routine and a process onto the ward round, so everybody knows what's going to happen next, that once we've done the social introductions, rehearsed the clinical problems, asked the patient, we're then going to get the vital signs. Then after that, we're going to do this and so on, all the way through. So that gives us quality control that we're doing it and not missing stuff. And it's very easy to miss stuff on a busy post-take ward round, or you're dealing with an angry patient, you've had a lot of interruptions, you may forget that you've done something. I can't remember what it was I forgot yesterday, but there were a couple of things on the post-take ward round that the F1 spotted I'd missed on the post-take ward round. What I've learned from the quality control, I've really told you that. I thought I was good at all these things, but first 3 or 4 weeks we were using this quality control process, I found I wasn't good at all. I wasn't good at active decisions about CPR status. I hadn't been asking properly about pain, hadn't been removing cannulas, catheters, hadn't been doing the VTE thromboprophylaxis, had no interest in pressure area care up until we started doing this. We were very poor on the emphasis on eating and drinking. Really bad. I was really bad at looking at what the juniors had written in the notes. I'm still pretty bad at that. I've now got to the stage where I actually sign it off so the juniors know I'm going to look at it, but actually to read it and see whether it makes sense, I'm still pretty poor on that. My patient reviews were not organised and systematic. They could start wherever they wanted, go wherever they wanted, whereas now they're focused on the main problems and then a systematic patient safety check. We were really bad at our communications with our nurses, and we still are, and as bad at drug chart reviews as well. We also developed a quality control system for our drug charts, and if you've worked with me on the ward rounds, that teaches you as juniors what's really important on a drug chart, brings our drug charts up to much safer standards, exposes our nurses to much less risk of getting it wrong. Perhaps the most common failings on quality control at the moment, failed to put the patient's name on page 2. That's the page the nurse has open when she's administering the drug. So if you haven't got the patient's name there, you've immediately exposed her to the risk of giving the drug to the wrong patient. And then the next, legibility remains an issue, and failure to put indication and duration for antibiotics. And people still writing MCG. A man died in our hospital 18 months ago, and one of the contributory factors was writing MCG, not micrograms in full. How anybody can write MCG on a drug chart when that's happened in our hospital, I don't know. Drug charts, so I was putting patients, nurses and juniors at risk by lack of thorough review of the drug charts. Very basic errors are common, not training juniors in how to read a chart in the same way as a radiologist reads an x-ray. So I can read a drug chart in about 8 seconds, I think, now, and spot the errors on it. And then go to the more advanced level of should they be on all these medications. So dealing with complexity in high-risk ward rounds, relying on memory is inadequate. I had 19 patients to see on my ward round today. Most of them had 8 clinical problems each. I can't remember all those, so I use a laptop. I put the information on there. But don't forget that at the bottom of the list they got iron deficiency anemia, even though they came in with an acute myocardial infarction, so there's a chance we won't miss their colonic cancer. My list of things that I do on the review, I'm better at that, I'm more trained at it, I can't remember all that, so I've got somebody watching me to make sure that the team all together do things. So we use the checklist to ensure completion, reliability, process. It stimulates team working. It means juniors are much more likely to interrupt when I'm about to make an error or a mistake. It makes the conversations around the bedside much more professional. Rather than, how's my patient? Fine, good, let's move on. We really understand why the patient is well, why they're ready for us to move on. So there's nothing special about my checklist, but how do you, as consultants or you as registrars in training, how are you going to satisfy yourself that your team has done it all for the patient at the bedside and that your team knows your process of care? Within team communications, I think the minimum team for a ward round is, for a structured review, must be the patient, the doctor and the nurse. One of our patients had a structured review by the vascular surgeons yesterday, which was really good, apart from the fact the patient wasn't on the ward. So that doesn't sound like a proper review. And if we don't have the nurse there, it's not a proper review either. The nurse, to me, is the hub of patient care. It should be the person who knows everything about what's going on with the patient. So the nurse at the bedside on general ward rounds in Worthing, and we did in my ward rounds and other consultant ward rounds, is possibly about 50%. But I've just looked at my figures for the last 4 months on Ditchling ward, and nurse at the bedside was 41%. This morning I saw 19 patients and had a nurse at the bedside on one case. This is Friday. Patients at risk all weekend. Could they go home? What's going to happen? What's going to happen if they deteriorate? No nurse there to tell me the basic functioning of the patient, their progress to plan, or what on earth we're going to do this weekend if they go ill. So is it any surprise that at weekends we get poor outcomes when the nurses don't even know what we as doctors think is wrong with the patients? And we might be wrong in any case. But if we're not all got a common understanding, it's not surprising care goes wrong. So I say nurse is the hub of patient care. If we haven't got a nurse at the bedside, we get no report on the progress against anticipated trajectory, no report on any unexpected events, no report on safety issues such as the drug chart, catheters, no report on mobility, self-care, no mutual understanding of the diagnosis, investigations, plans, date of discharge, poor explanations to relatives, no one to execute the plans. So I might go around and say, take the cannulas out, take the catheter out, trial without catheter today, home tomorrow, no nurse there, nobody hears, it doesn't happen. Patient stays in hospital, immobile, gets pneumonia. No one to explain and reassure the patient. And then we get these inventions. Let's have another ward round. Let's have a board round to make up for the fact you didn't do a good ward round. And nurses on our ward terribly keen we do board rounds. I say, well, why don't we just have the nurse there at the bedside? Then you'll all know what's going on. So why is there no nurse at the bedside? There's a lack of emphasis from us as consultants, or perhaps we've given up hope. I also think we're training a generation of juniors who've never seen nurses on the ward round, so they don't understand why it's so important. And then, when the nurse is there, they don't know how to talk to them. There's not enough ward staff to do the necessary work. Ditchling, we're short of 6 healthcare assistants with very heavily dependent patients now. So if we're short of 6 healthcare assistants, it's not surprising I don't get a nurse with me on the ward round, because the nurses haven't even got the patients out of bed, washed, toileted and fed with their medications by the time I do a ward round. We're also short of 1.5 whole-time equivalent nurses. I think there's also some inappropriate prioritisation in the nursing side. James Walker on AMU said he couldn't come with me on a post-take ward round one day because he was having to do a single-sex bay audit, which any child over the age of 8, I think, could do by going around and saying, are you a man, are you a woman, and are you all men and women in this bay? But then, so there's some inappropriate prioritisation. We also bog our nurses down with too much paperwork. And then there's consultant behaviour. Do we arrive on time? Are we professional? Do we get the ward round to go through in an appropriate time? And outliers. Terrible effect of outliers. We usually try and find a nurse to speak to at the end of each bay to tell them what's happened. Today we left the second bay in Ditchling because we had to go to Erringham, then we had to go to Coombs, then we had to go to Burlington. So we haven't seen a nurse from the second bay in Ditchling at all today to talk with about the patients. And we couldn't go back and see her because the F1's bleep was going off so incessantly from Coombs. Why haven't we got there yet? So outliers have terrible effect on communications within the team. Time is running through. How do I train juniors on rounds? if you're a consultant, I'd suggest you should visualise a perfect but busy ward round. How would you like the ward round to be? And in those days, I wanted the notes trolley to be laid out in order with a place marker in each place, the notes really written nicely, the junior able to present the case succinctly, all the end of bed folders there, a nurse, so you got it all. You know how you want to do it. And Elena Karnovich one day actually managed to do that, get all the notes laid out in order, the place markers, and it just felt so good on the ward round because everything's organised in place, easy to get right, like a good pit stop. Once you've visualised your perfect ward round, then you should be able to describe that, which in business terms is standard operating procedure, and you should be able to tell the juniors whether they're up to standard operating procedures or not. My main sort of formative feedback to the juniors at the moment is you're really good, you do good assessments of the patients, get the presentation down to 60 seconds maximum. So if you've got to be off by 10 o'clock and you've got 14 cases to work through between 8 and 10, you can't spend 10 minutes a case presenting them. So how can you in 60 seconds present a case where it convince me you've really thought it through, you've highlighted the important positives and negatives, and really cracking on with the work? Allow juniors to feedback on your performance. I've had, over the last 6 or 7 years, 80 different people feedback to me about my performance on ward rounds, and that has changed my ward rounds probably more than anything else. People saying, why don't you try this? You could have done that. Don't think that was a good way to do things. Raj Patel is a consultant in geriatrics now, a tremendous person at giving constructive, formative feedback to change behaviour and enhance my ward round process. Change the roles. I let the juniors be the spokesman. I learn a whole lot about good consultation techniques. When the juniors are the spokesman, I learn about their management of their cases. I see they do the job really well, so I know on the days when I'm not there, it's right to entrust the juniors to do that work. More recently for the SPRs, I started giving them structured feedback on their night role. Did they delegate the work well? Did they identify the sick patients? Was the clinical care up to standard? Did they look after the juniors? Junior on Wednesday night was so good, I asked the juniors, the F1, did he give you a break? Did you have coffee overnight? And she said, no, we were working all night. So feedback to the SPR, sadly, was just make sure they get 10 or 15 minutes break. And he thought that was really good. It's something he'd missed, something that would be helpful for future night work. Other points I've shown you the ward round trolley. We've got stationary holders on ditching so you can actually find things like the CPR forms, the continuation sheets, the blood test forms. Go to another ward, don't know where they are. Use of the laptop is really, I've found really helpful. Electronic discharge summary we should be using across the hospital. It would help with communications for discharge and readmission. I do my ward rounds one bay at a time instead of going to one patient backwards and forwards. That relies on the laptop, so I don't rely on my memory. Our IT system seriously hampered our flow of work now. I could not be a junior doctor. I don't think I would resign because working in this hospital is so turgidly slow. You know what you want to do for patients, but nothing helps you to do it. It's sort of impossible to get it right, not easy to get it right. Safari ward rounds seriously reduce effectiveness, safety and team working, and we should do everything we can in the organisation to eradicate Safari ward rounds. I don't know why there isn't a general surgical male ward, general surgical female ward, so all the surgeons only work on 2 wards. I don't know why orthopaedic surgeons have to go to 6 wards to see 8 patients. It doesn't make sense. Is there enough time? So, you know, the Chief Executive wants us to spend more time doing direct clinical care, so if you're a consultant this week, I'd suggest you had your extra half direct clinical care time devoted to ward rounds. Manufacturers of highly complex products like BMW cars or iPods, they don't ask, is there enough time to produce a decent product? They say, how much time does it take to produce a decent product, and that's how long it's going to take, and then can we make it quicker, whilst maintaining safety, productivity, and reducing costs. So we're constantly under pressure in the hospital. Get the patient out quick. I had a patient sent home in the pouring rain this week, in an ambulance, admittedly, in her nightie and her dressing gown when she had a full set of clothes brought in by a relative so she'd go home fully dressed and warm. And the relative said the nurses were being told, get the patient out quick. That's not quality work. We've got to make sure, we've got to know what's important. The time is doing this really well, and it's the other bits that maybe we need to drop. And I hardly ever go now to governance meetings and to patient safety committees and things, because I think if we got this right, you wouldn't need the governance meetings, you wouldn't need the patient safety committee meetings. Ward rounds are crucial to our business. Of course, I know you all do outpatients as well and procedures and things, but this is just thinking about the ward rounds. The outpatients and procedures should be done really well. Should we do anything else before we provide high-quality rounds, outpatient sessions, procedure sessions? So I think ward rounds are the pit stops of acute care. They require a fully trained functional team. They require easy-to-get-it-right processes. They're immensely complex. They require time, carefulness, quality checking. Poor performance on rounds may be at the root of many of the ills of the NHS. I was invited to go to the mid-staffs inquiry only because I'd done the studies on whether we got the nurse at the bedside. And the guy running the mid-staffs inquiry was interested in this very basic failure of the common everyday processes and the impact that could have on all these outcomes like we've seen in mid-staffs. I find this interesting, stimulating work. I think the effort involved pays off in staff who work better, more fulfilled. Patients certainly more grateful and appreciative. I believe clinical care improves, although it's very difficult to prove. So my challenge for you today really is, what are you going to go and try on your ward rounds, see if you can improve your processes? Thank you.